Assalamu alaikum and good morning to everyone. I am Dr. Mohammad Shawanur Rahman Naeem, Intern Doctor, Dental Unit, Community Based Medical College Hospital. I would like to express my heartfelt gratitude and warm welcome to our Honorable Chairperson Sir, Director Sir, and all of my respected teachers and beloved colleagues for active participation on our today's clinical meeting. Today's topic is management of traumatic dental injury in maxillary anterior teeth. And our today's honorable chairperson is respected teacher Dr. Khaled Mohammad Islam Sir, Associate Professor of Department of Prosthodontics and Head CBMCB Dental Unit. And our today's speaker is our respected teacher Dr. Farzana Anar Ma'am, Assistant Professor, Department of Conservative Dentistry and Endodontics. Now I would like to request to our Honorable Chairperson Sir, Dr. Khaled Mohammad Islam Sir, to come on stage and take his seat to conduct the rest of the session.
Assalamu alaikum. Good morning to everyone. First of all, I like to thank Dr. Naeem for his nice opening speech. On behalf of Dental Unit, Community Based Medical College, I am Dr. Khaled Mohammad Islam. Welcome to you all again. Today's topic is management of traumatic dental injury in maxillary anterior teeth. Basically, this is a common case regarding in our dentistry, in our daily practice. Especially this occurs in our adolescent or children cases for many reasons. One of them, road traffic accident, fall from height, and nowadays violence is one of the major cause. And today's speaker is Dr. Farzana Anar. Dr. Farzana Anar, he is an assistant professor of conservative dentistry of Community Based Medical College Dental Unit. He passed BDS degree from Chittagong Medical College Dental Unit 2005. Then she achieved FCPS from BCPS 2018. And she is well active and well groomed and also a registered clinical endodontist. And also she is member of Bangladesh Endodontic Society, life member. And I think this case is really helpful for everyone, especially for young general dental surgeon, because they should have learned how to manage these cases immediately and also after follow-up treatment. Now I would like to request Dr. Farzana to come on the dais and conduct the rest of the session.
Honorable Director Sir, Honorable Chairperson Sir, respected teachers, my dear colleagues, and my beloved students. Assalamu alaikum. I am Dr. Farzana Anar, Assistant Professor, Department of Conservative Dentistry and Endodontics. Welcome you all on today's clinical meeting. My today's meeting topic is management of traumatic dental injury on maxillary anterior teeth. Introduction. Trauma of the oral and maxillofacial region occurs frequently and comprises 5% of all injuries for which people seek dental treatment. Among all facial injuries, dental trauma are the most common. Dental injuries that causes fracture, displacement or tooth loss lead to negative significant functional, aesthetic and psychological effects on children. Greatest incidence of dental trauma, male-female ratio are 1.5:1. In primary dentition, within 2 to 3 years, causes are start to work, accidental falls. Trauma in mixed dentition. Actually, mixed dentition within 7 to 9 years, it means milk or deciduous teeth and permanent teeth both are present in oral cavity. That causes are hyperactivity, contact spores, fall from height. In permanent dentition, accidental falls, spores, playground injuries, traffic injury, accidents, violence, and so on. There are a lot of classification of dental injuries. Among them, Ingalls classification are most authentic and significant. This is divided into three main groups: soft tissue injury, laceration, abrasion, contusion. Luxation injuries, concussion, subluxation. Actually, concussion means injury only confined into the periodontal ligament, not tooth mobility and displacement occur. But in case of subluxation, there is some degree of mobility and displacement may occur. And extrusive subluxation means outer movement of the tooth from socket, and intrusive luxation means inward movement, that means axial direction of the root. And avulsion means complete displacement. I want to tell it again. Complete displacement out of the socket is called avulsion. And hard tissue injuries are uncomplicated crown fracture. Uncomplicated means these fracture confined only dentin and enamel, not involve the pulp. And complicated crown fracture is usually it is involved the pulp, crown root fracture and root fracture. Now, case. My patient Shajib Mia, 16 years old male, hailing from Bormi, Mauna, with a complaint of sharp severe pain and fracture of maxillary lateral incisor for 5 days. According to the patient's statement, he was relatively alright 5 days back. Then he got injured by sudden trauma in the upper anterior segment. His medical history nothing contributory, and he had no experience any previous dental treatment. Actually, my patient Mr. Shajib Kalamia worked at garments factory as a part-time worker. He used to load lorry at the evening time. During his working time, suddenly he fell from lorry and got injured. On spot, he lost his both upper maxillary center incisor and injured or fractured on both lateral maxillary lateral incisor and soft tissue laceration. With all of these complaints, he came to CBMCB and got admitted under oral and maxillofacial surgery department. They took immediate measure for management and corrected a mild movement of the temporomandibular joint. After subsiding the emergency condition, they refer to this patient at conservative dentistry and endodontic department for further traumatic tooth management. Then I received the patient, and after taking proper history, his clinical examination are there was no facial asymmetry, no extraoral swelling, and that time temporomandibular joint was quite normal. And in intraoral examination, gingiva and oral mucosa is not inflamed, and teeth, avulsion of maxillary center incisor and fracture of both maxillary lateral incisor. On investigation, pulp vitality test, tooth was vital. Both maxillary lateral incisor was vital. Periodontal probing and no tenderness on percussion. And I prescribed radiograph, orthopentamogram, and intraoral periapical view. This orthopentamogram showing These orthopentamogram showing complete absence or avulsion of both maxillary central incisor, and there is a fracture line on maxillary lateral incisor. Actually, in this hazy image, actually it is not found the fracture line, but fracture line was completely visible on intraoral periapical view. So, my diagnosis is avulsion of both maxillary central incisor and complicated crown fracture on both maxillary lateral incisor. And treatment plan, extraction of the fractured crown, because just for fracture line, his crown portion was so mobile. That's why I had to extract the crown portion. single visit root canal therapy on both canine teeth, multi-visit root canal therapy on both maxillary lateral incisor, followed by post-core crown and bridge prosthesis. Before going to the complete procedure, I explain the whole step or procedure to my patient and his father as well. Then I had to extract the crown portion. So extraction of crown portion from maxillary right incisor and removal of fracture fragment from maxillary left lateral incisor. Then single visit root canal on both maxillary canine teeth and multi-visit root canal therapy on both maxillary lateral incisor. Then I gave intracanal medicament calcium hydroxide for 14 days. This is the initial image. This is the initial image after removing the mobile extraction, mobile crown portion. That's why remaining tooth structure is so little amount, and this little amount of crown is completely unable to hold any sort of crown prosthesis. That's why I had to do surgical crown lengthening. And surgical crown lengthening means complete removal of the 2 millimeter gum portion. Excision. আমারটা ওই যে ব্যাগে রয়ে গেছে। আচ্ছা, থ্যাংক ইউ। তো এটা কোথায় চাপ দিতে হবে? লালটায়? ওকে, থ্যাংক ইউ। Okay, I had to excise excision on gum portion 2 millimeter and 2 millimeter removal of the hard tissue and make the crown portion larger. That's why it may carry the cap prosthesis. So surgical crown lengthening on both maxillary lateral incisor, because both maxillary lateral incisor was so little amount of tooth structure, sound tooth structure was so little. That's why I had to make it larger by surgical crown lengthening. And after surgical crown lengthening, preformed metal post placement. Preformed metal post placement just for additional strength and core build up with glass ionomer cement. I used type 2 glass ionomer cement in this case. I want to mention this. I took this photograph with the permission of my patient. My patient was so cooperative with me. And this photograph after the surgical crown lengthening and core build up. Now this crown portion is large and this is completely ready to hold any sort of crown prosthesis. It may be metal fused porcelain crown or zirconium crown as well. Then metal fused porcelain crown prosthesis and periodic follow-up. Actually, it was my patient's desire that he wanted to get metal fused porcelain crown prosthesis because zirconium crown is so expensive, but my patient was belonging very low socioeconomic condition and his father was so poor. That's why he wanted a very cheap type of crown, that is metal fused porcelain crown. Moreover, I want to show the final phase of my patient with this normal type of porcelain crown. Please have a look. This is my happy patient. See his smile. This is initial radiograph and initial photograph, and after core build up and after getting the 6-unit bridge, the final image like this. So happy my patient is. Actually, after receiving final bridge, my patient and his father was so happy that his father that time actually started to cry. That was so emotional situation. This is my conservative OT. Isolation with Rabadin. Rabadin provide dry and clean operative field. Application of local anesthesia with 2% lidocaine. Working limb determination with apex locator. 0, 0 means tip of the file reaches to the apex and tooth length was 18.5 mm. Then biomechanical preparation with rotary files. Vigorous irrigation. Vigorous irrigation with 5.25% sodium hydrochloride. And now time for cleaning with paper point. And obturation with Silapex, calcium hydroxide based sealer, Silapex. And obturation with Gata Pancha. GP removal with and now time for post placement. I choose number 1 metallic post. This is pre-formed metallic post. Metallic post for maxillary lateral incisor and impression taking and model preparation with hard plaster. Then time for core build-up with type 2 Fuji glass ionomer cement. This is my happy patient. Soft. Thank you audience, thank you for watching.